big welcome to all my colleagues in Asia, especially in Singapore. Now, I'm going to talk about high flow nasal oxygen. Sorry, let me just get this. Yes, here we are. Okay, so what is high flow nasal oxygen? Well, it basically allows for the delivery of heated and humidified oxygen of up to 60 liters a minute and an FiO2 of 100%. Now, how does it actually work to improve the clinical outcome? So it's sort of multifaceted, and you'll have to go through a couple of components to see that what it basically does is improves the oxygenation, decreases actually the work of breathing. It has an effect in reducing the stress response, especially to the lungs, and all of this serves to improve the clinical outcome of the patients. So it's heated and humidified. That allows for reduction in the airway resistance. It improves mucociliary clearance, so secretions are easily expelled. And it also reduces mucus plugging and hence the ensuing atelectasis that can occur. Now, it actually washes out the upper airway. And this is actually quite important because if you look at ventilation per se, about 20 to 30% of ventilation is actually your dead space gas. So this is actually inhaled, but doesn't take part in gas exchange. So you can see in this model by Muller and his colleagues, as the high flow nasal oxygen is applied and increasingly from 15 to 45, you can see that the dead space gases are washed out, especially at higher flow rates. So effectively now when patient breathes, actually it's no longer the dead space that they're breathing, which is inefficient ventilation, but it's purely 100% oxygen. So this serves to actually decrease the respiratory rate. So it actually increases your minute ventilation, yet you do actually get an improvement in your carbon dioxide. It also does generate a positive pressure. So it's estimated that you get a PEEP of between 2 and 7 centimeters of water. And this is dependent on whether the mouth is open or closed and what the flow rates are. So at a maximum flow rate of between 50 and 60 liters a minute, you can actually generate PEEPs of 7. And there are some experimental models that they've done in which they have actually applied flow rates of like 110 liters, and they've been able to achieve PEEPs of about 10 to 15 with those. So apart from the PEEP, this also helps to increase the end expiratory lung volume, which is another reason why the oxygenation improves. Now, if you think of what your maximum inspiratory flow rate is at the peak inspiration, it's something between 60 to 80 liters a minute. Now, if you're going to apply 15 liters of oxygen, there's no way it can match that demand. Hence, you'll get entrainment of air. But with high flow nasal oxygen, because you're able to match the maximum inspiratory flow rate, hence it allows you to deliver that FiO2 of 100%. Again, another reason that improves the oxygenation. Now, one other very important aspect of high flow nasal oxygen is the reduction actually in the transpulmonary pressure. So in spontaneously breathing patients, the major determinant of this pressure is the inspiratory effort. That's actually sometimes measured by the negative deflection in the esophageal pressure. So what happens in respiratory failure is that you get this intense respiratory effort. And this causes uncontrollable swings in this transpulmonary pressure that may actually induce lung injury with the ensuing changes in the tidal volumes. This also changes the vascular transmural pressures, hence you get a lot of fluid shifts within the lungs. And it's sort of postulated that this actually increases the risk of like patient self-inflicted lung injury. which can then predispose to further sort of lung injury as the patient progresses in their clinical picture. What we do know is, and this is an interesting study by Maury, that you actually get a decrease in this swings in the esophageal pressure. Hence, it's sort of postulated that this reduction actually may be one of the mechanisms behind the efficiency of high flow nasal oxygen and just preventing this damage. So there we have it. So it sort of works on like a multitude of levels, like I said, and all of it basically seem to improve oxygenation and have a role in minimizing the impact, especially with lung injury to these patients. So, I mean, in terms of indications, I think, some of us use it in anesthesia. So I tend to use it, say, for especially for the morbidly obese patients that are having either awake intubations or procedures such as OGDs or colonoscopies in which they require to be sedated, but I'm a bit conscious about the airway. Of course, it does improve your apneic oxygenation time, especially with the rapid sequence inductions, and it can be used as a form of airway management or tubeless airway management in upper airway surgery, like in Thrive or S-Thrive. But let's specifically look at some of its applications in critical care and what we can do. So I think as one of the initial slides showed, so what it can serve is to minimize the need for invasive ventilation. Because all of this started with the Florali study back in 2015. And basically the question that they asked was, high flow nasal oxygen when compared to NIV or standard oxygen therapy, what impact did it have in decreasing the intubation rates and mortality rates in patients with acute respiratory failure without hypercapnia? So it was a randomized controlled trial with 300 plus patients that included patients with PF ratios of less than 300 who were not particularly hypercapnic. And note that in the exclusion criteria, there was no chronic element. So there's no cardiac cause or chronic respiratory cause in it. The patients didn't have any neutropenia and were relatively stable. So what they found, so when they divided it in the high flow nasal oxygen group, the NIV group, and the oxygen group, you'll note that in the NIV group, the tidal volumes that they achieved were actually relatively high, so 7 to 10 mils per kg. And this was administered for about over 8 hours. And in between the NIV sessions, they were actually given high flow nasal oxygen. Now, if you look at the results, so there was actually no statistical significance in the patients that were intubated between all three groups. They were all the same. However, there was a difference in the all-cause mortality and ICU mortality, which was favorable in the high-flow nasal oxygen group. And specifically, if you look at the more sicker patients, those with a PF ratio of less than 200, those that so less of them were intubated, and the mortality was even was superior. So the question is there a role in the self-inflicted lung injury that could have minimized this? So you'll note that there was no delay in the time to intubation between all three groups. So the outcome was just due to the oxygen strategy. Now, the NIV group also received high flow nasal oxygen, yet the mortality in the NIV group was significantly higher. So it sort of might be the case that the high tidal volumes might have induced some form of lung injury that led to the intubation and likely the poorer outcomes. And in fact, even within that group, those that had higher tidal volumes actually did worse. And this has been seen in similar studies in which patients that have higher tidal volumes receiving non-invasive ventilation actually do worse. So just moving on, so that what else can we do? So once we have patients on it, how do we avoid delaying intubations? Because as we know, actually delaying an intubation actually increases the risk of morbidity and mortality by up to 50 to 60%. So what one mechanism or tool can we use that has been that's been assessed? So one is the introduction of the ROX, or the ROX index. So that looks at the ratio of the oxygen saturation over the FiO2 and the respiratory rate. So in this study by Roca, in which I think there were up close to 200 patients, they identified patients that had acute respiratory failure and commenced them on high flow nasal oxygen. Now, they had a very strict criteria for intubation, which was a drop in GCS, increasing vasopressor need, as well as worsening acute respiratory failure. And they and note that in the baseline characteristics, actually there were quite a few patients that had chronic sort of liver disease, respiratory disease, and cardiac disease. So they almost fit with the sort of usual cohort of patients that we would see. And before I go through the results, just to give you an idea of what you can expect with the ROC index. So if you look at, say, a normal patient, say saturating at 98 to 100% on room air, you'd expect ROX of over 40. Somebody with severe ARDS, you'd expect a ROX of about 2.5, and the sort of COVID-y, happy, hypoxic patient saturating at about 70 plus on 100% oxygen, you'll expect a ROX of 5. Now, what he found is at particular timelines, at 2, 6, and at 12 hours, those with a ROX of above 4.88 actually had a low risk of intubation. And more importantly, those with ROX of less than 2.85 at 2 hours, less than 3.75 at 6, and 3.85 at 12, all had a higher risk of intubation. I think this is quite important because it gives us a sort of an objective assessment of what we can actually use to prevent delaying these patients on high flow nasal oxygen that require to be intubated. Now let's just move on to patients that have already been extubated, and what can we do to avoid the need to re-intubate them. So what we know is that post-extubation failure is the inability of the respiratory muscles to sustain the work of breathing, and this leads to progressive muscle fatigue. Now, it is associated with an increased risk of death, prolonged hospital and ICU stay, as well as the need for rehabilitation, and it's a marker or independent marker of severity of disease. Now, this is where high flow nasal oxygen actually might play a crucial role in preventing the need for reintubating patients. What we do know from these meta-analysis is that high flow nasal oxygen is better than standard oxygen therapy and non-inferior to NIV in reducing the need for reintubation. However, like this meta-analysis by Yunan Ni actually showed that although there was a decrease in the rate of reintubations, there was actually no reduction in mortality or the length of stay in ICUs. Yet there are quite a few studies that actually, like I said, quite supportive of this both in low risk as well as high risk patients. And I think the Hernandez study is probably one of the most quoted studies. So they basically divided their patients into two groups. They had a low risk group and a high risk group. So in the low risk group, they looked to see if high flow nasal oxygen compared to oxygen therapy reduced the risk for reintubation within a 72-hour period. Now, if you look at this low risk group, you'll see that Most patients did not have heart failure as the cause of the respiratory failure. There was no COPD. They were not hypercapnic during the spontaneous breathing trial. They had an adequate cough, and they were relatively well with fewer than two comorbidities. And what they found was with the high flow nasal oxygen group, less than 5% of the patients needed to be reintubated versus 12.2% in the standard oxygen group. And these were relatively well patients. And in the high risk group, i.e. patients that didn't fall into that category, when compared to non-invasive ventilation, actually high flow nasal oxygen was not inferior in terms of reintubation within 72 hours, in which almost a fifth of the patients required to be reintubated. But I think the key thing is that you have to start the high flow nasal oxygen early and at the highest possible flow rate, depending on the comfort level of the patient. Now, I'm going to very briefly talk about COVID and high flow nasal oxygen. Most of the treatment actually was instituted at Tan Tock Seng and our infectious diseases hospital, but the rest of us had a little bit of experience because of the initial spillover. But I have to kudos to my colleagues in the other hospitals, because I think Singapore has got one of the lowest mortality rates for COVID in the world, and also see the numbers are increasing now, and we are almost seeing a second, if not third wave in a lot of countries. So what is the best way of managing these patients? Now, unfortunately, there's been an outbreak of publications with COVID. As of June 2020, we've had something like 23,000 publications, all related to COVID, in which about 40% were actually research papers. So it's actually quite difficult to determine because it doesn't undergo the sort of usual scrutiny of peer-reviewed publications, because everyone's out there wanting to share what they feel has been beneficial for their patients. So and it's a valid reason. Yet obviously there's a lot of controversy. I mean, you have the greats like Gattoni and Marini advocating sort of an early intubation depending on the lung phenotype, and yet you have some that are having more of a cautious approach in terms of the early intubations. But what has happened is there's been an increasing use of other modes of ventilation, such as non-invasive ventilation and high-frequency nasal oxygenation in a lot of centers in the world. Now, high flow nasal oxygen is advocated by the Surviving Sepsis guidelines, by the Intensive Care Society guidelines in Australia and New Zealand, by the WHO, but not so much in the UK, at least in the initial publication. So I think things might have changed, because I know some of my colleagues in the UK still use it as a first line in a lot of their patients. So what are some of the fears? Well, that it's an aerosol generating procedure and there is a risk to healthcare staff. If we look at this paper that actually came out after the SARS epidemic that was published, I think, in 2012, they looked at the risk of transmission to healthcare workers. And actually, high flow nasal oxygen had a very low risk of transmission compared to some of the other means of ventilating patients. Currently, compared to, say, some of the other modes, such as NIV via a face mask or even a Venturi mask, the distance that the exhale air is dispersed is actually less than 20 centimeters. And I think this is probably an interesting visual description of what actually happens. So if you look at the different types of, so this is a computer generated model in which they calculate the spread and extent of the airflow, whether you have a high flow nasal oxygen or low flow via a face mask. You see that with the addition of a face mask, that severely disrupts, or in fact stops the spread of the airflow. And this is what's being advocated by everyone now. So when it comes to using high flow nasal oxygen, have a face mask over the patient with the high flow nasal oxygen. Obviously, then there's PPE for all the medical staff, and only utilize it in a negative pressure room or ward where the patients are cohorted to. What else is there to say? Well, so now a lot of patients use awake proning, either with adjuncts of high flow nasal oxygen, NIV, or oxygen. And it's sort of limited to small studies, single center studies, case reports, letters. So it's very difficult to tease out some of the information from this. Oh, excuse me. Okay. All right. So one quick study, I don't know what seems to be something wrong with my computer. Okay, so one quick study in which I managed to find about 200 plus patients that were diagnosed with high flow nasal oxygen and acute respiratory failure. And so 144 of them had high flow nasal oxygen, and the other 55 had prone positioning with high flow nasal oxygen for over 16 hours. Interestingly, the rate of intubation was actually almost similar in both groups. And although there was a slight delay in intubation in the patients that were prone with high flow, there was no effect on the 28-day or on mortality on the 28th day. All right, with that, I would like to thank you for your attention, and I look forward towards some questions, and I'll hand you back to Christian.